Hello friends, welcome to the Pathology Insights. Today in this video we will be discussing about the infective endocarditis, specifically about the etiopathogenesis and morphological changes which occur in the infective endocarditis. The lab diagnosis and the clinical features I will be discussing in my next video. So before going into the topic proper of infective endocarditis, let us see what are the layers of the heart. So the heart, the heart wall, it is made up of three layers. We have innermost layer, which is the endocardium, and this endocardium is lined by the endothelial cells. The middle layer is the myocardium, which consists of the muscles, that is cardiomyocytes, and the outermost layer is the pericardium. So the pericardium, it has two layers, that is a visceral pericardium which covers the heart, and we have another parietal layer of the pericardium which will be present on the inner side of the chest wall. So we have a cavity in between visceral and the parietal pericardium, and this we call it as the pericardial cavity. So these are the layers of the heart. Now endocarditis means it is the inflammation of the endocardium which is covering the valves and also the mural endocardium. So any inflammation of the endocardium, we call it as a endocarditis. Now it has again been classified as infective endocarditis and non-infective endocarditis. Under non-infective endocarditis, we have Libman-Sachs endocarditis and non-bacterial endocarditis. Now these two we are not going to discuss today. So coming to the infective endocarditis, again we have two types in this: acute endocarditis and subacute endocarditis. Now this classification, it has been based depending upon the virulence of the organisms, and it is on the basis of the clinical features and severity of the disease. Now today we will be discussing about this acute and the subacute endocarditis. So coming to the definition of the infective endocarditis. So as I told you, endocarditis means it is the inflammation of the endocardium. Infective endocarditis means this inflammatory process is caused by the microorganisms or the infectious agents. Now these infectious agents, they cause inflammation of the endocardium, which leads further to the formation of the vegetations. And these vegetations, they will be composed of the thrombotic debris and these microorganisms. Later on, this is also associated with the destruction of this underlying cardiac tissue. So because the endocarditis is caused by infective organisms, it has been called as infective endocarditis. Now, as I told you, it has been classified as acute and subacute depending upon the virulence of the organisms and depending upon the clinical features. Now we'll see what are the differences. Now what is the most common organism causing acute and subacute? Acute infective endocarditis is caused by highly virulent Staphylococcus aureus, whereas subacute infective endocarditis, it is caused by less virulent Streptococcus viridans. Okay, acute is caused by Staphylococcus aureus and subacute is caused by Streptococcus viridans. About the previous condition of the valves. So in the acute infective endocarditis, as the organism is highly virulent, it can even infect the normal heart valves. Whereas in subacute, it is less virulent and it infects already previously damaged heart valves. And lesions in the valves, usually in the subacute, they are not much of the, they doesn't involve underlying valvular tissue. They are mostly confined to the endocardium. Whereas in case of acute, they produce suppurative inflammation and they cause destruction of the underlying valvular tissue. And when we see the duration is it has an insidious onset and protracted course for more than 6 weeks. Whereas for the acute, it is less than 6 weeks. And what about the treatment part is acute infective endocarditis, it doesn't respond to antibiotics and the outcome is fatal. Whereas subacute, it responds to antibiotics and it heals with the complications. So these are the differences between acute and subacute infective endocarditis. Now coming to the pathogenesis. So in the pathogenesis, we have three predisposing factors which leads to this infective endocarditis. One is underlying heart disease. Second one is conditions that cause seeding of microorganisms into the blood and impaired host defense. So when there is an underlying heart disease which causes damage to the heart valves, there will be formation of the thrombi, and then the organisms come there and get enmeshed in the thrombi and grow there. Then for the infection to occur, there should be some source of the infection from where the microorganisms can come to the heart. So we should know conditions that cause seeding of the microorganisms into the blood. And host defense. So if the host defense is normal, obviously the infection can be controlled. So if there is an impaired host defense, then only the microorganisms from the source of the infection can reach the heart. So impaired host defense also forms one of the predisposing factor. Now, when we see the first predisposing factor, that is underlying heart disease, in this we can remember under two headings: valvular disease and congenital heart disease. Valvular diseases, the most commonest cause is rheumatic valvular disease. More than 50% of the cases they have rheumatic valvular disease. And other valvular diseases, we have mitral valve prolapse, degenerative calcific valvular stenosis, bicuspid aortic valve, then we have prosthetic valves. So if you see any of the heart valves, so valvular diseases, there will be turbulence of the blood flow. So whenever there is a turbulence of the blood flow, there will be damage to the endothelium. So this leads to formation of the thrombi, which becomes a very good site for the growth of the bacteria causing inflammation. Okay, then in the congenital heart diseases, we have patent ductus arteriosus, ventricular septal defect, coarctation of the aorta, then subaortic stenosis and pulmonary stenosis. Even all these congenital heart diseases also can lead to the development of infective endocarditis. Along with that, some other causes we have syphilitic valvular disease, atherosclerotic valvular disease, and the floppy mitral valve. These also can cause the predisposed to the infective endocarditis. So this all comes under the underlying heart disease. Now the organisms which cause infective endocarditis, and this the most commonest organism is Streptococcus viridans. This is less virulent, and this is one of the cause of the 50 to 60% of the infective endocarditis. Now in this, most of the valves are already previously damaged valves. In 20 to 30% of the cases, infective endocarditis is caused by the Staphylococcus aureus, where the valve need not be damaged. And in IV drug abuses, we have the Staphylococcus aureus infections. Now, other than Streptococcus viridans and Staphylococcus aureus, we have other organisms like Enterococci and the HACCP group, which can cause this infective endocarditis. Now, what is this HACCP group? So, H stands for Haemophilus, A stands for Actinobacillus, C stands for Cardiobacterium, E for Echinella, and K for Kingella. Other than those organisms, it can also be caused by gram-negative bacilli and fungi. Now, the previous Streptococcus, Staphylococcus, all that they can be cultured, but in some cases, organism may not be identified by the culture also. So we call it as culture negative endocarditis. Now, why though the organism is causing infective endocarditis, but we cannot get the culture positive is the patient would have used prior antibiotic therapy, or difficulty in isolating the offending agent, or the organism is deeply embedded in the enlarged vegetation that it cannot be released into the blood, so it can't be cultured. So these all conditions can lead to culture negative endocarditis. So from where this bacteria will come? So what are the sources of the infections? We should know. So the most common cause of the source of the infection leading to infective endocarditis are the periodontal infections. So dental caries or surgical procedures, surgical dental procedures, they can become one of the main source of the infection, or contaminated needles which are shared by the IV drug abusers, then infections of genitourinary tract, and certain surgical procedures like catheterization, cystoscopy, and obstetrical procedures, then infections of the GIT and pancreaticobiliary system, and also the surgical procedures which get secondarily infected. Then we have cardiac catheterization, surgery for the valve replacement also can also become a source of the infection. Then skin infections like the carbuncles, boils, and abscesses, they also can become source of the infection, and the respiratory tract infections. So all these infections and certain surgical procedures which get secondarily infected, they can become the source of the infection. Now, in certain procedures, certain bacteria or certain etiological agent is common. So, in the dental procedures, we have infection by the Streptococcus viridans. IV drug abusers, we have Staphylococcus aureus. Along with that, there can be Pseudomonas candida or the Enterococci also. And if there is a previously damaged heart valves, it is by Streptococcus viridans. If the normal valve is present, it is infection will be caused by Staphylococcus aureus. If there is a valve replacement, artificial valves, within 60 days, we have Staphylococcus epidermidis, Candida, and Hassel group. If the artificial valves are kept and more than 60 days has occurred, then the infection can be because of the Staph aureus and Enterococci. In case of IV catheterization, infection can be because of the Staphylococcus aureus. If there is a urinary catheter, then infection can occur because of Enterococci. Colonic cancers or ulceration, then infection can occur with Streptococcus bovis. And in immunocompromised patients or after antibiotic therapy, it can be because of the fungi. So these are the specific organisms which are the etiological factors of infective endocarditis in certain in the particular sources of the infection. Now, in this, what are the organisms which are culture positive and which cannot be detected by the culture? What are the culture negative? So, most of the common organisms, they are culture positive, like Staphylococcus aureus, Streptococcus viridans, Staphylococcus epidermidis, Enterococci, Streptococcus bovis, and fungi like the Candida. These are culture positive, whereas the culture negative organisms are the Hassel group, Aspergillus, Legionella, Coxiella burnetii, which causes a Q fever, Bartonella infection, which comes from the cats, and Brucella infection, which occurs if the person utilizes unpasteurized milk, Coxiella psittaci, the infection which spreads from the birds, and Tropharema whippleyi, which is the cause of the Whipple's disease. So these all the organisms are culture negative organisms. Now the last predisposing cause is impaired host defense. So as I told you, if the host defense is good, obviously he can fight back the infection, so the bacteremia or fungemia will not occur. But if there is a suppressed host defense, then obviously the infection will spread fastly. So we see in conditions like impaired specific immunity in lymphomas and leukemias, and in the cases where the patient is receiving cytotoxic therapy for cancer, and in the transplant patients where they use immunosuppressive drugs, and if there is a deficient functions of neutrophils and the macrophages, then also the patient will have the impaired host defense. So now we have finished this predisposing causes. The first one is underlying heart disease, which can be because of valvular diseases or congenital heart disease. Next one is the sources of the infections, which leads to bacteremias or fungemias, by which the organisms reach the heart. Third one is impaired host defense mechanisms. Now, what is the pathogenesis? So from the source of the infection, the bacteria enters into the blood, and through the vascular channels it reaches the heart. So in the heart chamber, specifically, the bacteria gets deposited on the valvular tissue. So because some of the organisms will have adhesion molecules which mediate their adherence to the endocardium, and typically these organisms will be depositing on the heart valves. So when, as I told you, in the predisposing factors because of the underlying heart disease, so there is a turbulence of the blood flow which cause damage to the endothelium. So when there is a damaged endothelium or loss of the endothelium, platelets start adhering there. So once the platelets start adhering, then the platelet aggregation occurs, activation of the platelet occurs, and slowly we have the activation of the coagulation system. There is a fibrin meshwork formation here. So bacteria which is present in the circulation, it gets enmeshed in this fibrin meshwork in the thrombi. Then in this, after enmeshing, it starts proliferating. So once it proliferates, it forms slowly, this forms the vegetation. So these vegetations will have outermost fibrinous layer, and the inner layer will have the proliferating bacteria and the platelets. Now, what is a classic hallmark of this infective endocarditis is we see vegetations on the heart valves. Now, what are the commonest valve which are involved is mitral valve and the aortic valve. So that is the valves of the left heart chamber. Only in the IV drug abusers we have inflammation or deposition of the bacteria or the valves involved of the right heart is mainly in the IV drug abusers. They can be single or multiple and may involve more than one valve also. And in subacute bacterial endocarditis, vegetations are found on the deceased valves. Already I have told you subacute occurs when there is a damage to the heart valve, whereas acute occurs in the previously normal valves also. So once the vegetations are formed, later what are the consequences? So thing is, either the vegetations, because the vegetations have the microorganisms, they can cause more inflammatory process and erode into the underlying myocardium, producing an abscess, which we call it as ring abscess. Or these vegetations can embolize. So when they embolize, they reach many organs. So in the different organs, wherever they reach, they can form abscess. So because these emboli has the microorganisms, there again the infection occurs and abscess is formed, or otherwise they can give rise to septic infarct, or they can give rise to mycotic aneurysms. And the vegetations of subacute endocarditis, they are associated with the less valvular destruction when compared to the acute endocarditis. Now when we see the location of the vegetations, they are located on the atrial surface of the mitral valve and the ventricular surface of the aortic valve. And this is according to the flow of the blood. If you see, the blood flows from left atrium to left ventricle. So when you have a turbulence during the flow, the endothelium which is facing on the atrial surface, it undergoes the damage. That's why here we have the formation of the thrombus and vegetations. Similarly, in the atrial valve, what happens? The blood flows from left ventricle to the aorta. So turbulence we see on the side of the left ventricle. There only we have the damage of the endothelium. So vegetations occur on the ventricular surface of the aortic valve. So the gross features, when we see the size of the vegetations, they can be few mm to several centimeters. Appearance is they can be flat, they can be filiform, or they can be polypoid. They can be polypoid, or they can be fungating also. They are usually gray, tawny to greenish, irregular. They can be single or multiple, and typically they are friable, and they are present along the closure of the cusps. And when we see the differences of the vegetations in the acute bacterial endocarditis are more bulkier and globular when compared to the subacute bacterial endocarditis. And in acute bacterial endocarditis, the infection is severe, so it can ulcerate and perforate the valvular tissue, and even it can produce the infection along the annular ring of the mitral valve. So it causes the formation of the abscess also, which leads to the ring abscess. Formation of the ring abscess. Later on, the infection even can spread to adjacent myocardium, producing the myocardial abscess. Now coming to the microscopy of the vegetations, we have three zones in this. The outermost zone, which is the eosinophilic zone, outer layer or the cap, it is more eosinophilic. It contains the fibrinous material and the platelets, whereas the second layer is more basophilic. It consists of bacterial colonies, and the third layer, it consists of inflammatory cells. Now here in the acute infective endocarditis, it contains mainly neutrophils, whereas in subacute bacterial endocarditis, it has a granulation tissue. So acute we have neutrophils with areas of necrosis. Subacute we have the granulation tissue, which consists of proliferating blood vessels, fibroblasts, and chronic inflammatory cells. This is the microscopic picture of the vegetations in the infective endocarditis. Now that finishes. We have let us summarize what we have seen. So first we should know the definition. It is inflammation of valvular and mural endocardium by infective and microorganisms, divided into acute and subacute depending upon the virulence and clinical features. So acute is caused by highly virulent organism like Staphylococcus aureus, and it infects the normal valves. Subacute caused by less virulent Streptococcus viridans, and it infects only the damaged valves. So there should be some predisposing factors for this. So we have underlying heart diseases like valvular disease and congenital heart disease. Then the source of infections can be there, which can be the dental procedures or IV needles, usage of contaminated needles, infections of GIT, pancreaticobiliary respiratory tract infections, and skin infections, which becomes a source of infection from where the bacteria spreads to the heart. Then the patient's host defense, impaired host defense also. So organisms, again we have culture positive, culture negative. Culture positive are the common organisms: Staphylococcus aureus, Streptococcus viridans, Staphylococcus epidermidis, and Enterococci, Streptococcus bovis, and then we have the Candida. Whereas culture negative, we have Hasselt group, Aspergillus, Legionella, Coxiella burnetii, Bartonella, Brucella, Coxiella, and Trophirema whipple, which causes a Whipple's disease. Now coming to the pathogenesis, on the damaged valves, we have the thrombi formation, which contains the fibrin and the platelets, and bacteria which is present in the blood reaches there and get adhered to the thrombi, and there it starts proliferating. It causes the endocarditis, and later on these bacteria in the thrombi gives rise to the vegetations. And what we see microscopically, the vegetations are, we have three zones. Outermost eosinophilic zone consists of fibrin platelets. Next zone consists, basophilic zone consists of bacterial colonies, and the underlying zone consists of the inflammatory cells. So that finishes about the etiopathogenesis and the morphology of infective endocarditis. In my next video, we'll be discussing about the lab diagnosis and clinical features. Thank you, friends. Thank you for listening patiently.